for joining us in our podcast, organized by CCM Health. I am Chief Medical Officer. My name is Dr. Avinash Jayaswal, and I have the pleasure to have with me as guest today Dr. Manijeh Berenji, who is our advisor on risk stratification and clinical outcomes. She is also a practicing clinician in Southern California, and she will present herself, of course, once I hand over the mic to her. So we are very glad to have you today for our podcast from Manhattan. I am here. She's joining me from California. And we will go into topics related to value-based care. And let's get going with Dr. Berenji. I'll just throw out to you the first question, and then I'll hand over to you the mic. So the first question we'll like to talk about today is, what's new in the population health space? Dr. Berenji?
Thank you, Dr. Jayaswal. So my name is Manijeh Berenji. I'm a board-certified occupational and preventive medicine physician. Been practicing for almost 10 years in a variety of different clinical spaces. And clearly we see some major changes happening in population health over the last couple of years. Clearly the COVID-19 pandemic was a major disruptor in terms of how we deliver care to our patients. We had to shift from primarily brick and mortar operation to almost a virtual operation for most outpatient clinical operations. So in the last 2 years, we've actually learned a lot about how we can diversify our clinical offerings to patients, meeting the patient where he or she is. It's been a very exciting time for me, learning about telemedicine and how we can incorporate some of these best practices into our day-to-day clinical practice. So honestly, I'm very excited about where things are going in this space. I believe that with the right tools, clinicians can really take advantage of a lot of these new technologies that can help optimize their clinical operations and their patient outcomes.
Sure. We'll get more into detail. As far as new rules that have come out, so like in New York, I don't know if Dr. Berenji, you have kept up with this new rule that came out that nurse practitioners have now full scope to evaluate, order, interpret diagnostic tests, initiate and manage patients, and even prescribe medications. So this is something, I don't know, what did you hear about this?
I have actually, and honestly, I think it's an exciting trend to see having more variety of providers, not just physicians. Clearly, nurse practitioners have expertise in their respective domains, ensuring that we're able to service as many patients as possible, especially on the primary care side. We do have a lack of providers across the country, including New York State. So I think it's a positive development. We want to be able to service all our patients, no matter where they come from. And if we're able to incorporate these nurse practitioners in those high-risk settings, in those communities where there are not many primary care providers, for instance, I think they could fill that void. So I think it's a matter of being able to take these providers and put them in locations where they're most effective.
Sure. Actually, New York is not the first. Actually, there's a bunch of states, maybe like 20, and the District of Columbia too, that went for this. So this is just to highlight that there is a shortage of physicians in the market, and we have communities that are getting inadequate amount of care due to that. And the practice of what's commonly called the practicing at the top of the license, where with one physician, there's around him a host of other providers, nurse practitioners, RNs, MAs, even social workers. So that type of setup has, of course, been very useful. This addition, as a law now, will, I think, in population health, will definitely make for avenues of outreach to patients that are seeking care. There is a lot of ground to cover in that aspect. So, yes, of course, as far as population health goes, there's new things coming out. We at CCM Health, we are keeping up with what we think is the best possible services that we can provide to our providers that can in turn then arriving to patients in the end. So one thing is our COCM offering, which is behavioral health integration, where we actually staff our providers with a licensed social worker and a psychiatrist as well. So the provider can actually take care of the patients that have, mild to moderate anxiety, depression, which is a large majority of patients don't need to go and see a psychiatrist, and the physician can actually take care of the patients himself. And with our help of, having the COCM program, he can actually do that. And those who have started it have, since January, and they have been very, very excited about it. So, yeah. The other area is AI, Dr. Berenji. AI is like the tool which actually will revolutionize, different areas. Medicine is not going to be very different. And, automation of workflows, cost savings, analytics, all these things which make for better care, because these are tools that the physician actually, if he can make them work for him, will translate into better care. We'll get into that into more details with the follow-up questions that are coming. So let me throw another question to you, Dr. Berenji. So what are the hurdles to navigate sustainable, high-quality, successful a path to value-based care?
So, that's an excellent question. And clearly, as we are coming out of the pandemic, being able to ensure that providers are able to provide the best quality service to their patients at low cost is going to be of utmost importance. These practices need to have the tools available to them to be able to do that. I know a lot of practices, unfortunately, had to close down during the pandemic for a variety of different reasons.
Sure.
New practices are popping up. How do practices develop that infrastructure that they need to provide their patients with the best quality care at the lowest possible cost? I think there are going to be hurdles with the payers, especially as we are trying to ensure that our patients are able to get the access that they need at the time that they need it, making sure that the providers are getting what they need out of the bargain. I think it's going to be an interesting dynamic to see how these specific medical practices exchange and interact with the payers, being able to create novel ways for payment. Clearly, bundle payments have worked in different iterations over time, but I think there's a new potential here to have physician practices, have these medical practices engage with payers, engage with the community, be able to find out what works best for the payers, the patients, and then be able to develop that basic infrastructure around bundled payments so that providers are incentivized to provide that great care, and you can see the results in the outcomes. So I think revisiting this whole idea of bundled payments is going to come back to the fray, and it'll be interesting to see how this develops over the next couple of years.
Absolutely. And this is, again, about change, right? So we are looking at a landscape that is changing. We are looking at already, it was changing, and then the pandemic kicked in, which has, disrupted. I would like to just say a word here about, the tech world. The tech world has been disrupting things, from like catering to taxi service. And the whole idea is to come in with technology and replace the main player and just go straight to the customer. here in healthcare, I think the tech world is going to be a little bit surprised because how do you replace a doctor? I mean, how do you replace a nurse? It's these are things which I think it's a hurdle because it has not been easy. I mean, if you hear, I mean, it's been a while since you've been hearing, the big names in tech have been, going into healthcare, and they're still at conferences. You hear them doing, new things, but we haven't heard like a huge change in the health landscape. And if you look at the projection for the next 5 to 10 years, the American budget for healthcare is just astronomical. I mean, the number is like hallucinating, which I'll come back to that later, Dr. Berenji. But yeah, change is something which is difficult, right? Do you want to comment on that?
Yeah, I mean, honestly, coming out of the pandemic, we're still kind of figuring things out. But I do feel that we have taken a lot of good lessons through the pandemic. I mean, I know I have as a clinical person practicing medicine, being able to service patients where he or she is, utilizing these tools that we now have at our disposal that, 2 years ago, we didn't even have. So I think it's a matter of incorporating these tools into how a clinical practice operates, ensuring that patients know how to use these tools. Clearly, many patients don't have access to high speed, internet or broadband. It's difficult for them to utilize some of these technologies, but I do feel that that is the future. And if we have, government, invest in some of these basic, infrastructure bits like, the broadband, for instance, so that patients can, interact with their provider in, whatever way that works for them. A lot of patients prefer to do telemedicine. They prefer to have that ease of communication right in their own home. And if you can incorporate some of the technologies like remote patient monitoring, for instance, you can capture those vital signs. I don't know if you know this, but there are so many different apps out there right now where you can do a visual acuity assessment. You can do a basic hearing assessment. You can get, heart sounds, and you can actually track a person's heartbeat. I mean, there's a lot of innovations happening, and I think it's a matter of digesting what's out there and creating a way for primary care providers, as well as specialists, to reap the benefits of these technologies and be able to incorporate these technologies into their day-to-day clinical operations. I honestly think it's a very exciting time. And I do think that with the right government spending, with the payers understanding that the dynamics have shifted, that patients want to be able to access their provider, they still want to see a provider. I don't think you can replace a doctor or a nurse, quite frankly. Patients really want to interact with us as clinicians. They enjoy it. I mean, that was my experience through the pandemic. I mean, I remember when I was seeing this one patient via telemedicine, and, this patient literally was waiting to talk to me to tell me about what was happening, with respect to his diabetes and his blood pressure. People want to interact with us. And if we can make it easier for them to access us as a collective, I think that's going to really benefit the patient. It's going to keep them engaged in the process. They're able to relay what's happening, whether good or bad, to us. And then we can make the appropriate decision so that they don't end up going to the emergency room, for instance. We know that that's a big ticket item when it comes to cost. But a lot of times patients end up going to the emergency room because they have no other alternative. They couldn't get a hold of their primary care doctor or their specialist.
Sure.
So I think technologies that are coming out, and the portals and the dashboards and the tools that we have to make it easier for the patient to access us is going to be a game changer.
Absolutely. One very important point, with what we do is we have, of course, the platform, the EMR, the chronic care management EMR, but we also have the human component. So in population health, we're offering both. And as a physician myself, I don't think that, we are at a point where people will be talking to a screen and, get their whole care and not have that human interaction. Is just so, it's one area where, Dr. Berenji just mentioned it, replacing a physician, a nurse. It's I mean, it's something for science fiction, in my opinion. However, there are other things which technology actually can replace, like, for instance, replace. Let's talk about social determinants of health. Okay, very in area to delve into a discussion. However, it does actually make for so much of problems as far as care and getting care to people. So, the health equity, right? So there are three aspects. So there's wealth, there's power, and there's prestige. So these three things, once an individual is deprived of, is actually translates into lesser health outcomes. And technology is a wonderful tool to bring a level playing field. I mean, everybody has a phone. I mean, even in third world countries, people maybe live in huts, but they still have a cell phone. So that can be a game changer. You don't have to replace the human being, the physician, but you can actually enable people. Same thing, Dr. Berenji just mentioned about, RPM. So cellular technology. You don't even have to rely on the Bluetooth Wi-Fi connectivity. The device is actually just going straight to the platform. So these new tools are the big game changer. And in the pandemic, people were locked into their houses. By the way, in China, they're still doing lockups. So big. I mean, the whole city of Shanghai is locked up right now. Imagine. So they have taken the route of not vaccinating the whole population. So that's when you have a very sort of like top-down type of approach to healthcare. So to tell you, so yes, technology actually has become even more important in our work, but in healthcare, it will also make for a lot of possibilities. So our RPM service is very good. We have the platform, of course, to do RPM, and that is fed back to the provider as data. And we'll talk about data in a bit. And the data can actually then be used to provide better care and reduce the risk taking. So yes. Just one thing, and then we'll move on to the next question, Dr. Berenji. Regulations, right? So the regulations, they are there. They are there whether you like it or not, and they can be helpful or burdensome. Do you want to comment on that?
I mean, regulations are here to stay. I think that's just part of the healthcare landscape. But I think it's important to have good advisors to guide medical practices through the various different regulations around brick and mortar clinical services, clearly telemedicine. There's discussion about, how are we going to continue to operate with, at least for specific, primary care providers, specialists. There's been a lot of changes in the telemedicine space as it applies to healthcare delivery. So clearly, we all have to do our due diligence to keep up with the regulations. But at the same time, it's great to have an advisor or a person or a group that you can trust to help you navigate through this landscape, because it's hard. We as clinicians, our main job is to take care of our patients. And, being able to identify, what regulation is going to impact our bottom line. That's a lot of things that we have to be able to handle. And sometimes, we have to be able to utilize our time wisely. So being able to take advantage of those advisors, those groups that have a good handle on the regulation piece, and then being able to take those pearls and apply it to your practice. To me, that's money and time well spent, because at the end of the day, it's all about taking care of your patient. If you can get that good clinical outcome, if you can ensure that your the patients in your panel, whether young or old, are getting the medications that they need on a timely basis, that they're coming in for their regular checkups on a timely basis, that you have, systems in place to be able to track when a patient is not getting what they need. I think that actually will help us as clinicians not only do better when it comes to patient outcomes, but we can get a good handle on the regulatory piece as well.
And that's an area where we help our providers. So, next question to you, Dr. Berenji. What is disrupting the population health sphere?
Yeah, I mean, we've kind of brought up a couple of different, disruptors today. I mean, clearly the COVID-19 pandemic continues to disrupt. We're trying to, coexist with this virus and clearly ensure that our patients are getting their health needs met. I'm sure you've seen this, but a lot of patients during the pandemic didn't get their, screenings for, colorectal cancer and breast cancer. So we're seeing an uptick in some of these cancers as a result. So as clinicians and as public health professionals, we need to do what we need to do to get these patients back into the fray, making sure that they're getting their screenings, making sure that they're coming in to see us. We don't want to neglect all the other healthcare needs of our patients. And, as we kind of phase into this endemic phase of the COVID-19 era, how do we coexist with, this virus at the same time provide that high quality service to our patients and making sure that we're addressing all their healthcare needs. So I think we're still kind of, navigating through this space. Clearly we have a lot of work to do. Making sure that our patients know how to reach us and access to care is such an important thing. So I always want to make sure that whatever we are doing as we navigate through this landscape, that we always remember the patient and always remember that access is key. It is the key driver for good outcomes. So at least for me, being able to take advantage of these new technologies, and I know we keep talking about these technologies, but it's such an important thing because it's really revolutionized how we are able to connect with patients. And to me, being able to utilize these technologies to the best of our abilities is really going to help us deliver the best quality care for our patients.
Absolutely. Totally agree with you. And again, back to technology. So the idea is to, embrace a provider-focused approach to disruption, right? The idea is not to replace the physician, but to enable him. And we're talking about screening. Of course, with the pandemic, we got straight into, war zone mentality, and we had to because it was terrible. 2020, 2021 until we got a grip on this. So as far as prevention goes, the routine prevention, the CCM program. So we have the nurses that will be part of the practice of the provider will be taking care of this screening. All this is prevention. This is what they do, part of the CCM program. And the RPM, of course, piggybacks on the CCM to provide even more complete information for the provider to work with. And then there's the COCM, which I mentioned earlier, which is the behavioral health. So we are looking at disrupting what is a traditional way of working. We are looking at value-based care. So, of course, even before the pandemic, the law of the land was that patients or patient outcome is going to determine physician score. And the Affordable Care Act of 2010, there's the MACRA. There is, of course, out of those legislation, you have the MIPS, you have the Medicare Star Rating. So it's like the patient experience. And going forward, we are looking at value-based care becoming even more, grounded in deep roots, in the sense that, the payer is going to ask for more for the dollar that they spend. we're talking about for Medicare is the federal, the federal agency that is the payer, and for other payers too. But here we are, if we can just focus on Medicare for a moment. So, of course, when you're paying, you want to get the bang for your buck. So, what do you want? You want that the law, which is value-based care, is that it's applied in a manner where we are getting the most out of it. So we are looking at in trillions of dollars. The projection is $6.2 trillion in 2028. I mean, the number, I don't know how many zeros is after that one. It's 6. So it's huge. So the idea is to do something where at least we are trying to do something about it. So the value-based care makes sense. However, applying value-based care is not easy because you have to embrace change. We are talking about quality measures. We are talking about EMR. We're talking, switching to EMR. We are talking about PCMH accreditation. All these are quality benchmarks that make for better practice. And with the CCM program, where you have more control over your patient population outside of your office, then it's like a full circle back where you're able to have control and you're able to exercise better informed decision. And of course, with your quality measures that you would have chosen, you can focus on those because you have nurses working on those quality measures for you. So you choose them. At the end of the year, they have made sure that your quality measures have been met. And then you go into the next year with a better score, and so on and so forth. The score adds on itself. And again, we are looking at, it's like a classroom where there's a curve. And the A might be a 95%, but an A can also be an 85% because it's a curve. So you're continuously being judged by the performance of your peers in the same specialty as a whole. So you are being judged with other doctors across the country. So, and these tools are there to be used in order to have good clinical outcomes. So it's a disruption which is already happening, and it's getting even more so. And the idea is to use those disruptive forces to your advantage, because if you're looking at $6.2 trillion being spent in healthcare in 2028, and if you're getting penalized, means you're not even receiving a chunk, you're actually, paying. And, penalties, they go into a cash register to reward those that are getting rewarded. So, of course, there's, like in everything, more people getting penalized. So hopefully, these things catch on quicker, and providers are able to grasp that this is, not something which is supposed to become problematic for them. Change is never easy. It's like a toddler that has to learn how to walk. It just takes effort. But once he walks, he doesn't want to go back to crawling. So it's the same thing with riding a bike and driving a car and maybe a helicopter and so forth, or going into outer space. So it's always a progress, and that requires some effort. Same thing, value-based care requires some effort. There's technology tied into it, quality outcomes tied into it. So we want to be your partner in this. And there's also the regulatory aspect, contracting, which is changing. There's in the new Medicare, the direct contracting that has been overhauled. We are looking at social determinants of health that is tied into that, the health equity. And the flexibility, because of the pandemic, has also been tied into there. So the changes that are happening it's taking into account things that have happened, recently. So it's a moving target, and you have to keep up with it. And I hope, our podcast here and others that will be coming will be helpful for you to remain engaged. So moving on to the next question, Dr. Berenji, how does data help better population health initiative?
Yeah, clearly it's all about the data, right? If we're not capturing the data, then it's hard for us to be able to monitor how our patients are doing. How are we going to assess outcomes? Clearly, having good data infrastructure is vital. Having a very robust electronic health record system, which is user-friendly, is crucial. Being able to train your providers on the EHR and making sure that you're capturing as many of those key metrics as possible. I know Dr. Jayaswal mentioned what's happening with CMS, and clearly, as part of the CMS Innovation Center, they're trying to continue to move the needle when it comes to outcomes. So if you don't have a good data warehouse where you're collecting all this information and you're able to generate those reports to CMS, you're able to demonstrate that you're meeting your objectives when it comes to patient outcomes, you're going to be falling behind. But there is hope. I mean, there are so many tools out there that clinicians and practices out there can use to be able to help them kind of get through some of these hurdles that they have to overcome. And honestly, a lot of these metrics are pretty easy to get. It's just a matter of ensuring that you're collecting the data systematically, that the data is being warehoused appropriately, that you're able to generate those reports in a timely manner, and you're getting those reports out to your stakeholders, whether it's the payers, whether it's CMS, what have you. So data is a crucial piece of this. And I mean, we know that in the population health space, if you're not capturing that data, you're not going to be able to keep up.
And that's where technology can help. So we're talking about, data of different sorts. There's like silos of data. I mean, a very simple one is, if you're not embraced EMR, so you have, data that is stuck in paper charts, which is very tedious to go to and it's not accessible. So data has to be made accessible. So, this is one more time highlighting that this is not a luxury to switch to an EMR. Do it for your patients because your patients' data is going to be more accessible. One day you fall sick. One of the simple things, you get a really bad allergy, you're not coming in. Somebody else can look and take care of your patient. So data has to be made accessible. We're talking about actionable data like medication, your pharmacy, your health risk assessment. So, our nurses in chronic care management, so data that they shared, the idea is they produce data that is fed back to you. This way you have more data to work with, more information to work with, and you can make more informed decisions, and you can channel your energy into more high impact decisions because your decisions are more informed. Fall assessments, for instance, that itself is a care gap. If you don't do a fall assessment and the patient falls down, that's a preventable clinical situation. So the idea is to use data, make it more efficient, more cost effective, and move from a volume to an outcome-based system. So you're looking at having better outcomes, but better outcomes will happen when you're doing things upstream. So you're using the data in order to make the right decision, but it has to happen. First of all, you have to have it, and secondly, it has to happen upstream. If you're not doing preventative care, you're always going to be in that, receiving end of problems, and that's, again, we can very quickly just mention, fee-for-service type system where, you're just seeing the problem when it comes in the form of a sick patient, but you don't have to. You can do much better. And the idea is you use data, leverage it to provide better care, and use technology, AI, machine learning. This is part of the EMRs, the chronic care management EMR. It's like pattern recognition. The idea is to make the software read the data, understand what has to be shown, and use the information then to make more informed decisions. So all these tools, they are there, but if you're not using them, you're going to be losing and you're going to be penalized. And just a very quick mention about how data is so huge. I mean, Medicaid data, Medicare data. In New York, there's like several repositories of data because there's a regional approach. So there's a lot of data to be worked with, and I think here you can leverage the resources that are around you in order to, you don't have to do it by yourself. You don't have to. I mean, we are doctors. We are not, technology. If you're technology savvy, that's good. But if you have, a regulatory brain, that's very good. But you can get help. And that's where, our regulatory services that come part of our package of chronic care management, you leverage that to help you and navigate better going forward. Next question, Dr. Berenji, how to move beyond payer to an integrated value-based payment approach?
Yeah, I mean, that's a very complicated question. I feel like you need to bring all your stakeholders into the game. Clearly payers are a key part of it, but you need to make sure that you're engaging with your community, you're engaging with your fellow clinicians. I mean, clearly clinicians, providers, we're all in this together, and it's really a team-based approach. We can't be operating, in silos at this point in time, because you're not going to be clinically viable as an operation. I mean, that's pretty much the bottom line. So in order to be able to keep things moving in your clinical practice, you need to be able to engage with your fellow clinicians in your practice. You need to engage with your nurses and your medical assistants. It's all hands on deck at this point. If you're going to be able to take care of patients, especially with all their, chronic diseases, you need to have an integrated framework by which you can address their concerns. And at the same time, you have systems built that will create less work for everyone in the long term. So at the end of the day, it's really important that you have those relationships with all of the people on your team. If you're not able to have those huddles on a daily basis, if you're not able to troubleshoot issues as they come up, if you're finding someone is struggling and they're not able to keep up with the workload, it's all about people management too. We want to be able to deliver the best quality care to our patients, but at the same time, we need to ensure that all the systems are in place to be able to do so. Clearly the regulatory piece, that's always going to be there. But at the end of the day, I'm very hopeful. And I think we got to leave our clinicians with that sense of hope that not all is lost. We don't want to scare people into feeling like they're going to be penalized left and right. Focus on what you do best, taking care of your patients, meeting them where they are, utilizing these tools that we now have to engage with our patients, keep them active in the process. I feel like if we're able to really hone in on those things, we can really achieve what we want to achieve and have a very successful practice that is not only meeting all the objectives that CMS is setting out for us, but we're actually able to engage with our community and making sure that we're taking care of them like family.
Very important to mention that we help with our advisory board members, coaching you to transition from the payer to the value-based payment approach. So, the whole value-based care system is based on managing risk, and you have to be flexible. I mean, you have to be able to say to yourself that this is. I mean, I'm trying to think, how to bring this up in a manner which makes sense. So it's kind of like you have to sit down and kind of think, how are you going to practice in the next 5, 10, 20 years? And just take a moment and think about it. And once you come up with an answer, and that's just a superficial answer, but an answer that comes from deep within, then you have to be able to use the help. I mean, if you're not using the help and just doing everything by yourself, and say you're going to manage your 250 chronic patients by yourself, it's just so the help is out there. Dr. Berenji, what do you think?
Yeah, absolutely. The help is out there. We can't do this by ourselves. And, as clinicians, we want to focus on what we need to focus on, which is taking care of our patients. A lot of the other things we can actually take care of by incorporating these tools, by utilizing these services, making sure that they can take care of things on the back end so we can do what we need to do on the front end, which is ensuring that patients are getting the care that they need when they need it. So I do think it's possible. Coming out of the pandemic, I think this is a time for change, for growth, for innovation, for taking the lessons learned from the last couple of years and integrating that into a new way of doing business. And I think it can be done. And, practices can be viable and they can succeed and they can thrive as long as they are able to seek out those resources to keep their clinical practices in good shape.
In a partnership, you will have, a better sense of risk management, and you'll spread the burden of the risk that that you're being asked to bear. Because you're evaluated, because there's the MIP score, because there's the Medicare star rating, and others, and get help. We are a turnkey solution. We come in as your partner, and we go in at risk. We have to show that we are producing good quality care, and very simple. Medicare wants to show the numbers. Wants to see, the numbers that we are saving them unnecessary spending. So closing those care gaps and stratification of risk. That's your specialty, right? Risk stratification. Do you want to mention take that part, and then we'll be closing too, because we are getting towards the end here. Risk stratification. Why don't you take over?
Sure, Dr. Jayaswal. So at the end of the day, it's all about risk stratification. We have to be able to stratify our patients best based on their risk factors and based on the number of chronic diseases that they may have. That's going to be important to be able to develop ways to better manage those folks, especially the high risk folks. As we all know, those high risk folks are the ones who are the highest cost generators. So being able to identify those individuals, being able to create systems where we can reach out to these individuals, making sure that they are getting all their preventative screenings, for instance, those falls assessments, medication adherence. These are the low-hanging fruits that we can capture, and we can actually focus on those groups that are the potential or have the potential to create costs down the line. I mean, this is not rocket science. We know the basic principles here. It's just a matter of incorporating these new data infrastructures, having the electronic health record. It's there for a reason. It's there to make our job easier. And as long as we're able to utilize these resources, these tools, and we can actually do that stratification, and we can have those specific cohorts of patients based on the level of risk that they may have, that's actually going to help us achieve better outcomes on a whole. It's going to help the patient. It's going to help everyone. So at the end of the day, we need to do our due diligence to capture all those risk factors and be able to take the time to do that stratification. I know it sounds daunting. It sounds like it's a lot of work, but at the end of the day, putting in the work to be able to set up those stratification schemes, being able to identify those patients who are going to be needing those additional touch points, utilizing your nurses, utilizing your medical assistants. This is all hands on deck, and it's very important that we're able to stratify those individuals, identify those people who need more assistance, and being able to reach them where they are. And in that way, we're able to cut the costs for all these individuals across all these risk pools.
There's the 80-20 rule, that is 80% of resources is consumed by 20% or less. So if you spread out your effort like evenly through the 100%, that's not the way to go about it. you have to put in more effort where, your money is. I mean, where the outcomes are. Those people that need help. And that's where, chronic care management helps you manage those patients that are going to cost more and that are going to make your clinical outcomes look worse. And hence you actually focus on the problem instead of, like spreading out your whole, all your resources into everybody. So on this note, I think we are already at the end of the time that we allotted. So, Dr. Berenji, thank you so much for joining me from beautiful California. It's beautiful in New York too. And we will be continuing this conversation going, and our next guest will be coming, I think, in about a fortnight. It'll be Dr. Baran Erdik. And I thank you all for joining our podcast, and have a good rest of your day and stay safe.